The OnQ technology really helps with the quality of the MRI. I think it starts all the way from the acquisition of the MRI all the way through how urologists would use it, in a patient scenario. So the actual technology just helps us enhance the diffusion weighted imaging portion of that MRI. I call it diffusion weighted imaging on steroids. Kind of helps not only acquire images better, but then allows a radiologist to have concept acuity around where the tumors are located. And then we have a really nice map that overlays that image onto the T2 that most of us urologists look at for biopsies. And then if that map's overlaid, it kind of helps us decide where's that tumor, how many biopsies do we need to take, and are they candidate for certain treatments. So, when you're taking a look at a regular MRI, a lot of urologists don't tend to want to look at those images. It's very challenging to see there's some dark spots here or there. But when we have this overlay, it really helps describe when I'm in a patient scenario where we're going to take a biopsy or how important I think this particular lesion is. So that's really where I rely on it, is in first the patient encounter. So I can look at the images with the patient, and then at the time of biopsy, I'm really targeting those areas. And then after that, we're going to use that again for treatment discussions. And if you're uncomfortable reading the image or showing it to them, then you're less likely maybe to bring that image up. Whereas if you show it to them and then you can show the color overlay, like that's where we're going to do the biopsy. It just really connects then to go, okay, this is what we're going to do. And I think the understanding level is enhanced with OnQ. We're really focused on this clinically significant prostate cancer. And how can the imaging really sway me to do a biopsy or not? I think that's the first indication. If I have a spot and it's PIRADS 4 or 5 and our restricted signal map is kind of lighting up in that area, I'm going to be a little more worried about that. Or if it's completely negative, I just have an extra layer of confidence. Even when it's read by the radiologist, it's negative, I can still look at the overlay map and I see it's clean. I'm really confident that I should do a biopsy in that person. But I think it really does start with detection, right? Do you do a good biopsy? That informs your treatment decisions, and then kind of on down the line. So I think that initial quality image is important. I have one case where they already had a biopsy, they had low-grade prostate cancer, but there was this apical lesion that just didn't look right. And they said there may be some capsular bulging there, so I ended up getting another MRI with OnQ, and it kind of lit up. And I was like, I think we need to repeat this biopsy. I just wasn't trusting what was going on. So we ended up rebiopsying, and all the cores in that target area were higher grade prostate cancer, and he decided to do treatment instead of active surveillance, which is super important in his case because we would have probably delayed his treatment by a year plus.